Okay, good evening, everybody. It's actually 1:30 p.m. here in Boston. I'd like, first of all, to thank the organizers actually for this meeting for inviting me here today, and thank you for those attending the webinar as well. So let me introduce myself. My name is Hassan Mashbari. I'm a teacher assistant in the general surgery department at Jazan University. I'm currently a clinical fellow in trauma, acute care surgery, and surgical critical care at Mass General Hospital and Harvard Medical School. Today, we're going to be talking mostly about three main objectives. It's going to be, the first one is going to talk about the basics of ventilatory mode, because we have a different background of attendance. So what I'm going to do is just try to start with a simple breakdown of exactly what is the mechanics of the ventilation, then just go into more depth, a little bit complicated. So with this way, we can make sure that different backgrounds can pick up something from this presentation. So the first call is going to be talking about the basics of mechanical ventilation and modes. Then we're going to talk about how to adjust the ventilatory setting of acute respiratory distress syndrome in a patient with COVID-19. After that, we're going to talk about the alternative rescue measures in those patients who you have problem with their oxygenation after you put them on mechanical ventilation. Between each one of these objectives, we're going to pause to ask questions. And if there's no more questions, we're going to go proceed with the next topic. All right. So by the end of this presentation, hopefully that you will be able to understand the following concepts. With mechanical ventilation, we seek control of several key with the mechanical ventilation, usually seek control of several key parameters. The first of all is actually the respiratory rate. The second of all, exactly the tidal volume. The product, you can see the product between the respiratory rate and the tidal volume minus the dead space will give you what is the minute ventilation, which is exactly what is the ventilation that the patient is receiving. Number two is we also seek to control the amount of pressure to prevent a barotrauma to the lung tissue. This depends on the following. It depends on the transpulmonary pressure. And the transpulmonary pressure is basically the difference between the air inside the lungs and the air outside the lung, which is mostly during the during the following slides, we're going to explain to you more about that. Okay, and also we're going to be talking about what is the meaning of positive end expiratory pressure, which is the main reason for that is to prevent atelectasis at the end of exhalation. All right, so unlike natural breathing, where air is drawn into the lungs by negative pressure with chest wall expansion, mechanical ventilation is generally delivered with a positive pressure. We are pushing pressures into the lungs, meaning air is pushed down into the lungs. This flow and pressure is generated at the ventilator, travels through the ventilating tubes, down to the tracheal tube, into the trachea, and finally to the alveoli, will expand the lungs. Elastic recoil is provided externally by the combination of lung tissue and chest wall. Okay. Now that we have reviewed the basic concepts, let's start talking about the difference in modes of ventilation. To actually understand what kind of the difference of mode of ventilation, if you're able to understand these four questions, we will be able to understand what exactly the mode of ventilation you are dealing with. So here's an example. They're forming parameters that correspond to the setting of different mode of ventilation are these four things. The question number one, how is the breath triggered? The question number two, what is controlled during the breath? Number three, what is allowed to vary during the breath? And the last thing is how the breath is terminated. Are we going to go through If you can see here, you can see the VCV, which is volume control, pressure control, pressure support, is IMV, and pressure control. We're going to talk mostly about the three first top modes of ventilation in this particular, because to be able to go through every single mode of ventilation, actually it will take longer time than what I'm trying to cover during this presentation. All right, so let's start about the volume control. So let's start, as I said, let's start looking about the volume control. Volume control initiated with time. So time is what exactly initiate the ventilating, which is if we decided the time by actually deciding what is the respiratory rate. That, for example, if we said that the patient is going to take a breath 10 times every minute, so we are basically telling that the volume control initiated by the time trigger, meaning that it is set that the machine is going to give a breath to the patient every 6 seconds. All right. During the breath, the inspiratory flow is held constant. So when we say flow, it's the same thing as we're saying volume. So volume control is basically we are controlling the amount of the flow, controlling the amount of volume we push into. So again, going back to the four things we're going to talk what trigger, what we are controlling, what we are letting loose or variable, and how we are finishing how's the breath is finished. So we said in volume control, we set up the time. So time is the trigger by actually controlling the respiratory rate. We control the amount of flow, and the variable here is the pressure. And we terminate this breath by time. Again, it's something we basically adjust. And what we can adjust in a volume control is we adjust the tidal volume, and the machine itself will actually calculate and adjust the flow and the time in these patients. Okay, what about the pressure control? Well, for pressure control, again, we initiate the breath by time. So by defining what exactly the respiratory rate, we control the pressure here, and what variable in this patient is exactly the flow. It's the other way around the volume control. In this way, in this particular mode, we control, again, the pressure, and where we leave the variable is the flow, and we terminate with time. And here we do not adjust the tidal volume because we are not adjusting a volume here. We're basically adjusting a pressure set. Okay. All right. What about the pressure support? The pressure support, exactly, it's similar to the pressure control, but the main difference here is the patient himself is who trigger the ventilation, who is trigger the breath. So when the patient take a breath and reach a certain threshold, the machine that trigger the machine to actually give a breath to the patient. And when the patient is letting the air out, when it's reached a certain threshold, it's basically trigger the stop of the breath. So if you look here in the controlled and the variables, the pressure control, the pressure support in the controlled and the variable are the same, but the difference is what exactly trigger and what exactly terminate the breath in this mode. Okay, so breath started and terminated when flow threshold crossed, either by initiation or by termination. Again, understanding the two first pressure ventilatory mode, which is the volume control and the volume and the pressure control, you're actually able to understand the remaining ventilation modes in this in the mechanical ventilation overall action. All right, so what about the plateau pressure? So regarding the plateau pressure, the flow and pressure delivered to the patient. It is important to understand what is particularly important about this. When ventilating a patient, we are interested in limiting the pressure delivered to the patient to prevent barotrauma. However, the pressure measured at the ventilator is not the pressure delivered to the patient due to loss from flow resistance. Okay, so therefore, peak pressure measurement at the ventilator is not reflected of the pressure in the lungs. However, if flow is stopped at the end of inspiration, which is, I'm going to show more pictures so you can be able to understand that, which is called the inspiratory hold breath. If flow is stopped at the end of inspiration, pressure can be allowed to equilibrate throughout the rest of the lung system. Then the pressure at the ventilator will equal the pressure in the lungs. This is called the plateau pressure. The duration of the end inspiration, which if someone exactly asks you, like, for how long I need to do a hold inspiratory, and you can ask your respiratory therapist to do that. Actually even less than a fraction of a second can actually be enough, but it's different from patient to patient. So the duration of end inspiratory pause required for an active measurement plateau pressure can be as short as half a second, but may require much more or much longer for true equilibrium. So this is one of the topics that we said it's really important to understand, which is the plateau. So let's move on again to the next. So here, now let's look at the details at the flow and pressure waveforms for an example. This is, if you looked at the machine itself for the mechanical ventilation machine, there is 3 things you look at it, but let's take a look more of these 2 important things. It's flow and pressure. And the most important thing that I want you guys to be able to understand, if you looked at a mechanical ventilation machine, by looking exactly at these 2 things, the flow and the pressure, you actually can tell what mode of ventilation this patient is having. So let's talk mostly here on the volume controlled ventilation. So flow and pressure waveforms for an example of the volume controlled ventilation. As you can see here, during the inspiratory flow, during the inspiration flow, it's held constant, because I said before that volume control, the thing we hold as a constant is the flow. So here you can see the flow is constant, and at the end of inspiratory flow, it's briefly held at 0. And the reason why it's held at 0, this is to calculate the thing we talked about in the previous slide, which is the plateau pressure. So again, for the reason why we held it at 0 for the inspiratory pause before exhalation is to allow to begin. This is reflected down in the, if you looked at the pressure waveform, at the initiation of the inspiration, there is a jump in pressure from the flow resistance. Then you can see here that there is a progressive increase in pressure as the lung inflates. During the inspiratory pause, here again, the respiratory pause, if you try to, I want you to correlate between whatever you see down to correlate to whatever you see in the flow and the flow chart up. So now this is end inspiratory pause. During the end inspiratory pause, this is where you should measure the plateau pressure. Okay. With expiration, the presumed return to set PEEP level. So if we're setting up the PEEP to 5, now you can see that the line is not going all the way down to the 0, because we are already pre-setting this up to a PEEP of 5. Okay. All right. What about the pressure? So in contrast to the volume control waveforms, with the pressure control waveforms, note which parameters are constant and note which parameter is constant. So here you can see that the constant is the pressure. So there is abrupt increase in the inspiratory pressure that's held constant, and because when you increase all of a sudden this constant increased pressure, you can see a jump in the flow, but as long as the lung pressure is maintained, the flow will slightly start going down because you are achieving the pressure that you are already setting up the machine. And that's what is the most important difference between the pressure control and the volume control. Again, this is the how is the inspiratory flow in corresponding to a constant pressure, and what happened during the inspiratory phase and the exhalation phase. So again, just to compare it, the most important thing I want you guys to understand that the difference between the volume control, pressure control, I want you guys to understand what is constant. So in volume control, the constant is the flow, and it's the square shape. Okay, so it's the square shape is what is constant, and what is variable in both volume control and pressure control. Okay. All right. So what about lung protective ventilation? So before I go to the next one, I want you guys to understand the concept of what is lung protective ventilation means. Okay. So far, there is no single mode that have proven that improve the survival on a patient with acute respiratory distress syndrome. When we say about what mode, we're talking about, is our patients who are in acute respiratory distress syndrome, should pressure control or volume control is the best, or aprv, which is another mode, is the best. So far, there is no proven mortality benefit. But on the other hand, what is shown to be a mortality benefit is following the ARDS-net protocol. So what is the ARDS-net protocol, which is going to be talking about it more. So the ARDS-net protocol, to be able to provide a lung protective ventilation, is that you need to follow these following three measures. Number one, the plateau pressure should be less than 30 cc, and the less than 30 pressure. And the reason why is that if your goal to decrease to be less than 30, basically the chances of having barotrauma is less. The second thing is, what about, I hear okay, I hear an echo, but it's okay, no problem, continue. So what about the tidal volume? So for the tidal volume, to be able to achieve the lung protective ventilation, the goal is 4 to 5 ml. We're talking about tidal volume. The tidal volume should be 4 to 6 ml per kilogram predictive body weight, not an ideal body weight. Okay, that's in the ARDS-net protocol. So it's 4 to 6 ml per kilogram predictive body weight. And what we depend on the predictive body weight is height and gender. And there is actually already a pre-calculated charts that you can look at the height and see if this is a patient is a male or female, and look it up, and you can tell what exactly the two measures that you need to be. So, and you should write it down exactly in the patient chart that, okay, for my patient, if the 4 ml per kilogram predicted body weight is this number, and 5 is this, 6 is this. So this is, you can give your team a parameter that they can try to stay in between to achieve this kind of protection. And driving pressure is also, again, although it's a weak evidence, but also in some studies saying that driving pressure that is less than 15 also has some mortality benefits, but that's also a low, weak evidence. The second question is so how we are actually able to measure what is driving pressure, which is equal to the tidal volume the patient is getting. Tidal volume is you basically bring the PEEP minus the plateau, and the difference is exactly the driving pressure. So that's something that you also should target, and every day you're seeing a patient in ICU with acute respiratory distress syndrome. So this is what is the lung protective ventilation is all about. Okay. So what I'm going to do here is I'm going to pause for a minute, ask if there's any question, and then we can move on. So I'll okay. Dr. Abdullah, do you have any questions? Or that you notice any questions that...
I mean, you can, Dr. Hassan, do you hear me well?
I do hear you.
Okay, you can just ask the audience if they have any questions. They can, you see the panel, right? I mean, you can see their questions when they are there. So,
All right. So if that's okay with you guys, I'm just taking 1 minute just to go through the questions to see if there's any particular questions. Okay.
They can type it in.
Yeah, okay. So I don't see any questions. Please, guys, about SIMV. Yes, we will try to talk about that. And if that is okay with everybody. But I want to move on to the two most important topics, which is how to manage these patients with the acute respiratory distress syndrome. All right.
That's the presentation.
All right, so I'm going to reshare again my presentation, and I'll move on. All right. So this is the ARDS.net, and I will basically share it with you guys. And it's a concept that multiple people able to come up with. And if you look up here, there's a little bit of difference of what I said, and but I will discuss why there is a difference in the upcoming slides, including number one, what is the tidal volume that you should start with? Because if you look at the ARDS.net, they said start with 8, like here, like number 3, set ventilatory setting to achieve tidal volume of 8 ml per kilogram productive body weight. So they advise you to start at 8, but with a goal that after a while you should go down to 4 to 6 if needed. And we'll talk when exactly you need to go to that particular parameter. But that's one of the differences that I want you guys to be able to understand. And the ARDS.net study that was done in 2001, it's actually comparing a tidal volume of 12 ml per kilogram versus 8 or 6 ml per kilogram. And they looked into mortality in these patients, and they found that there is a higher mortality and utilizing a very high tidal volume in these patients with a little bit increase in the barotrauma as well. So that's where we came up with the where the study recommended a lower tidal volume in these patients actually correlate with a less mortality and a better outcome. All right, so let's dig into the main topic of this tonight. So which mode is easier for non-intensivists? All right, because we might be going into a problem that we don't have enough personnel, enough critical care physicians, that we might end up asking non-intensivist physicians to start taking a role in an ICU care. So when we start talking about aprv vent, and we talk about a pressure control mode, and we talk about SIMV, or we're talking about volume control mode, for a non-intensivist, we recommend them to start with the volume control, because in this setting, it's really, really, really easy to be able to understand and troubleshoot, but also at the same time, I'm like able to adjust the vent. So and these are the things that you should, after you basically choose the volume control mode, the 4 things that you're actually going to be targeting is tidal volume. You're going to give a respiratory rate. You're going to get a PEEP, and you can an FiO2. So, all right, this is where we're going to start. So for acute respiratory distress syndrome, per the ARDS.net, you start with an 8 ml per kilogram productive body weight with a goal of going down to 4 to 6. For respiratory rate, you can go between 12 to 18 to 20. For PEEP, start at 5, PEEP of 5, and FiO2 start with an FiO2 of 100%. Okay, that's the first thing you should do. All right, so what to do after you basically do this, and the patient is already, I'm only talking about the patient is already intubated. We're not going to talk about how you're going to intubate the patients with a COVID positive suspicion. That's a talk for another day. It's a big debate. There's so many methods out there, but all of them, they're saying that try to make sure that you watch there's a lot of videos, and just protect yourself. And we can if that's one of the suggestions, we can, at the end of the talk, if you have questions about that particular topic, I'll be more than happy to share the policy that we have and what we are doing right now, or we can decide to do that in another talk. Okay, so you set up the mode, you adjust these 4 things, and in 20 to 30 minutes, get an ABG. Okay, then you start fine tune after that. But the question is like how fast you titrate down. Okay, so that's also dependent exactly what is the problem that you have. So before I go into the problems, the what I do is immediately, if a patient, and I look at the ABG, and that's also another talk. You're going to take a look at the pH of the patient. You're going to take a look at the CO2, and you're going to talk about the partial oxygenation, because what we have is so far in a patient with a COVID positive patient with acute respiratory distress syndrome is a hypoxic respiratory failure. So your main important thing that you want to take a look at is the partial oxygenation in these patients. So if you look at exactly your PEEP and you look at FiO2. So what I do is they have really good oxygenation, because I'm also in a FiO2 100%, which is like eventually that's a toxic to the patient. You need to go down. So I immediately go down to from 100% to 80%. And then I start like every 10 to 15 minutes, I start going down by 10 on the FiO2, and then just wait and take a look at the pulse ox, take a look at the oxygenation, but also keep an attention that the recommendation, if you're going to go down on the tidal volume, so one of the recommendations they say, if you want to go down by 1. Let's say you are in 8, you want to go down to 7. By 1 every 2 hours to 3 hours, and you will find different people saying different things. For a FiO2, immediately go down to 80% unless the patient oxygenation start deteriorating. Then go down by 10 to 15% every 10 minutes, with a goal going down to 35 to 40%. Okay, so let's say now you put the patient on a mechanical ventilation and you start having a problems. The question is that where are the problems can come from? So there may be 3 main problems that you might face. So it's going to be either a problem of one of these 3 things. Is it a problem in oxygenating the patient? And when we say oxygenation, it's mostly partial oxygen pressure and the pulse ox that we're looking at. If we're talking about there's a problem in ventilating, that's basically there is a problem in washing the CO2 outside the patient body. And mostly we see that through looking at the CO2 and the pH on an ABG. Or there is a problem in a pressure, okay? And we're going to address every single one of them. But let's start with the problem with the pressure. And when we talk about problem in the pressure, we're talking about, are we looking into a peak? Are we talking about a plateau pressure? And what is the knob that we control in the mechanical ventilation that control these 2 things? So it's number 1, is it if there is a problem in the pressure, now I'm looking at the mechanical ventilation, and the normal, what we said is that we want the plateau pressure to go down less than 30. So here what I do for every patient I intubate, I take a look, the machine will immediately give you the peaks, but it will not give you the plateau. And I told you how to measure it. You do an inspiratory pause for within like half a second, and you're going to get that. And I actually take a look and see, is the plateau and the plateau and the peak are almost the same? Then basically I can say that the peak is representative of the plateau. So now every time I take a look at the machine and it's giving me a number above 30 pressure problem, then I'll tell you like, oh, okay, I already said that the peak is almost correlated to the same to the plateau, although usually it's less than by 5 to 6 or something. Then if I see that, then I say, oh, if there's already a problem in the peak, yeah, I'm going to check the plateau, but I think I have a problem in the pressure. So the first thing you need to do, or you can do, is going down on the tidal volume to the recommended ARDS net, which is 4 to 6, but go down to 6 first, okay? And 2 questions that you have to think about is that When I go down in the tidal volume, what's the problem? If you went down in tidal volume, remember that one of the problems that you might start facing, because for oxygenations is the PEEP and FiO2. Ventilation and washing CO2 is tidal volume and respiratory rate. So if you went down on the tidal volume, one of the things that you need to keep in mind that you are expecting to have an increase in the CO2 in your ABG, and actually acidos decrease in the pH level, all right, which is we're going to talk about, but just keep that in mind. So that's where the concept of permissive hypercapnia came to, is that you're going to go down to the tidal volume down to 6, and you're going to watch the pressure. If you're down to 6 and the pressure is still above 30 and plateau, then that means you still need to go down on your tidal volume. So you can go down to 5, try again, and then go down to 4. But with taking into consideration that accepting a permissive hypercapnia, it's acceptable. High CO2 is not dangerous for the patient. Low oxygenation is dangerous, but how high I can accept a high CO2? All right, so you're gonna have a patient in the CO2 of the normal 35 to 45, but you're gonna see patients in the 50, you're gonna see patients in the 60, and you're gonna see your pH is going down 7.27, 7.30, up to, if your pH is above 7.20, it's okay. You can live with that. So you have a pH of above 7.20, and your PCO2 is in the 60s, and a patient has no intracranial trauma or anything that you're really worried about, having a high CO2 might actually vasodilate and increase a problem. And mostly these patients are one single organ problem. It's a respiratory from COVID patients. So you are okay in that, and you should accept that permissive hypercapnia. In fact, if you are aiming to have these patients a normal ABG, you actually might cause more harm for the patients, because now you're going to start thinking like, I don't like this pH, I need to wash out the CO2. You're going to start increasing the respiratory rate to, and you can increase the respiratory rate, but to up to what? Like up to 20 to 22. But just keep in mind that permissive hypercapnia is an acceptable concept to limit, which is your limit is 7.20, 7.25 pH. Okay. So if it's below the 7.20, then that's where the problem, mostly cardiovascular complication and arrest from the severe metabolic respiratory acidosis in these patients. So I just brought in this as an example about what is the low pH can cause you. Okay. I hope this is, it's really important. I want you guys to understand the concept that that mostly the non-intensivists think that it's my job is to make sure the numbers look good. Okay. ARDS is a different beast. All right. So we talked about the pressure problem. We talked about a ventilatory problem. Actually, when we're talking about the pressure, especially in tidal volume adjustment and hypermissive hypercapnia, what if you have a problem in your oxygenation? Okay. If you have a problem in your oxygenation, is the problem is PEEP, is FiO2, is a ventilation mode? Well, the first thing you can do is actually adjust the PEEP. All right, we said that we're going to start at a PEEP of 5. But if you look in the ARDS net, there are already 2 scales. If you looked up here, there is the low PEEP, high FiO2 schedule or scale, and there is the high PEEP, low FiO2 scale or schedule. So you should follow this schedule. And actually, per the studies and reports that we have so far, is that they're saying that the COVID patients with acute respiratory distress syndrome, these patients simulate like a pulmonary edema kind of situation or scenario. That's why they really love to have them on a higher PEEP, low FiO2, like which is the lower half of the schedule that I'm showing here. So follow that one. Okay, although we're hearing some now in Michigan and other states that they're saying that they are better in the lower PEEP, but the majority of people, this is a pulmonary edema kind of situation picture. It's not a pulmonary edema, but it looks like pulmonary edema in which they love having a high PEEP. And so you should follow that schedule. All right. But if you're increasing the PEEP following this schedule, how high you can go? So you can go all the way up to 22 to 24 of a PEEP, and that's really high already. But one of the most important things you need to know is the patient is a PEEP responsive or not, okay? And you see that by actually checking ABG and you're looking at the patient oxygenation. So let's say you're 8, you went up to 10, you went up to 12. You're actually saying either the same oxygenation or there is actually worsening of the oxygenation. So your patient is a PEEP non-responsive. So you need to think about other measures. So instead of saying, sorry about that. Instead of like, oh, I'm gonna wait and do nothing till my patient reach all the way to 22 to 24, then that's not how you should think about it. The patient already showed you that I'm not a PEEP responsive, especially if they start getting worse with a higher PEEP. You have to think about other measures, which we will talk about as well. All right, so what are your adjuncts? Okay, so again, before the last portion of the presentation, I'm gonna stop for a minute here, take a look if there's any particular questions. All right, low oxygenation more dangerous than higher CO2, great statement, okay. Report EKG arrhythmia like SVT, would you think adjust your sets? Yeah, there's a lot of good, interesting questions. So I think some of these questions might actually be answered in my next portion of the presentation. So if you guys can excuse me, I'll finish this portion of the lecture, and then we'll definitely gonna go through the questions, and I'll be more than happy to answer them. Okay, all right. Sorry about that. Okay, all right. So what are your adjuncts? So there's 4 things that you can do, and the question that is asked is that which one of these I should do first. All right, so there is paralysis, there is a change of vent mode, and we'll talk about vent mode, we're talking about aprv. We should talk about each one of them. Then the pruning, which basically switch the patient from supine into pruning position, and the tummy, or ECMO. So I really encourage everyone who's taking care of a patient in an ICU that you need to understand exactly what are the facilities that you have and the adjuncts that you have in your hospital. For example, do I have, which is we're going to talk about, do I actually, my team able to manage or able to how can I say that, able to understand how aprv mode is, which is even, that mode is even still confusing to some of the intensivists. So I would not ask non-intensivist patients to start doing aprv modes because it's not an easy thing to understand, but I'll try to explain it as well. What is that meaning? And do I actually have an ECMO in my program? Do I have a pruning team, or my nurses, is my nurse ratio are enough to take care of pruning patients? So if you have one nurse taking care of 3 patients, there is no way you can actually have 3 prone patients with only one nurse taking care of these 3 patients. Not only you need how many people you're actually going to be able to use to be able to help you flipping the patient into pruning position. So all of these things you need to look at. And the question that you also need to think about it is that where is the closest hospital that can offer ECMO to my patients, and establish, especially with this era of pandemic, establish a way of communications, either know how to consult that team, how to discuss that with them, and what is their bed capability, and if even needed that, is it that a team was going to come to my hospital and do the ECMO cannulation themselves and to move the patient there, or is it they want us to do it and then like actually I'll ask my cardiac surgeon, whatever the team, that to do it in your hospital, and that then you transfer it to that patients and they will do it there. Okay, so I really not sure where exactly each hospitals have, but that's something that whoever is taking care of these patients are responsible for taking care of these patients is to talk with the team about this particular policy. So sorry I talked more details about that, but it's really important that you guys need to know what do you have in your hospital. Okay, all right. So paralysis, which one you should start first? So the good thing about paralysis is if you are a non-intensivist, that can give you time. You can give rocuronium, you can give it a one-time spot and see how much that do for you for your oxygenation. Most of the patients you'll see that they either have a better synchronization with the machines, with the ventilation machine, but also you can achieve that with actually really good sedation and some pain medication. But this will buy you time if you are non-intensive. This will buy you time to explore other options. Like for example, all right, so while I'm waiting to get an ECMO team, or I'm waiting to have people help me how to do pruning, let me just go for some paralysis for a while till I be able to discuss other ideas with other people. So it can buy you time. It does not show any improvement in mortality and everything, but it will help you with synchronization of the vents with the patient. All right, what about changing the vent mode? All right, so the APRV, which is airway pressure release ventilation. So Dr. Matt Martin, who's an amazing trauma surgeon in the West Coast of the US, he said when he was trying to explain what is APRV mode, is that it's the same as you're trying to teach your patient how to do an incentive spirometry. So incentive spirometry is the same as that machine you give it to your patient after your surgery with a ball, and you ask them to take a deep breath, and you basically see the ball go all the way up and down. So the first thing you do, the patients will not understand. So usually they start blow out, and instead of actually breathe in through the straw of the thing. So you need to tell them no, this is actually you breathe in. And then they start doing this. They take a small, quick breath, and then they stop, and the ball go up and down. But you need to tell them no, actually, I want you to take a deep breath for this ball to go all the way up, and I want it to stay up. And that meanwhile is basically by having that ball up, you're basically giving enough breath and then increasing your inspiratory period or length or time if you're in inspiration to open more alveoli and decrease atelectasis before you let the ball go down. So then they tell them, all right, then let it go. Then they let go. Then immediately tell them, I want you to take now a bigger and a longer deep breath as well. So this is exactly what is APRV. It's you trigger four things. It's called a P high, which is pressure high, P low, pressure low, T high, which is time, and T low. So you ask the patients is every time they start triggering the vent, they will take a deep breath. And the difference between the incentive spirometry and the ventilatory machine is that actually the vent will be doing that for them. So at certain time, the vent will give to whatever you set up the P high, which is, let's say, for example, you set it up for 330. So then immediately going to give all of a sudden this high pressure to 30. And then you basically got a longer inspiratory. So like 5 kind of seconds. Then that will have enough time for the atelectasis to open and you recruit more alveoli for your oxygenation. Then you're basically after that time, that the inspiratory period, which is longer than the expiratory period you're adjusting, you let it go. Then the pressure will go down. Thus you're going to give a short exhalation, then immediately give another longer breath. But you decide, like exactly as you said. If you said 10 breath per minute, that's mean every 6 seconds. But also in the same time, it's also a combination with the pressure support. So in between this mandatory breath, the patients are allowed to initiate their own breath. So for example, so in between, let's say you're saying that 10 breaths a minute, in between breath number 1 and breath number 2, the patients are want to generate their own breath. The machine will recognize when they reach that particular threshold that, remember when we talked about in the pressure support ventilation, immediately give that patients the pressure support that they needed. And most of these patients are really comfortable with this ventilatory mode. You're going to find the places that are APRV shenanigan, like they're passionate about it, they love it, all their ICU, and that's the only thing they do. And you're going to find some other centers that they actually do not believe in the APRV, and they even do not do it. And reason why, for some of them said it does not work, and others said it's actually work. But majority of the patients from the experience, and we talk to people, majority of the patient you will see an actual improvement in oxygenation. But how correlate that to the actual mortality improvement, I'm not sure, to tell you the truth, and not that many people actually know the answer to that. All right, so we talked about two so far. We talked about paralysis as a temporary. We talked about changing the vent mode, and I hope you guys are able to understand what is APRV is, and I'll be more than happy to explain it again if someone did not pick it. All right, what about pruning? All right, let's talk about pruning. So for pruning, is two things that you really need to think about every time you start thinking about doing a pruning. All right, so what if your center does not have an experience? So also, again, Dr. Martin was saying that every hospital who do a spine surgeries, the OR nurses are actually trained in how to do this, how to prune the patients for back surgery, for the spine surgery cases. So the easiest thing to do is actually bringing those nurses or the circulators in the OR and let them teach your ICU nurses or a team who you can delegate that to be your pruning team. And they basically teach them how to do it safely, okay? And you need at least 4 to 5 people. And like, for example, looking at this picture, you have 4 people because one person has to make sure that the ET tubes stay in place when they prone the patient or actually put the patient back to spine, because there is a chances that you might take the central line out and the patient get bleeding. And unfortunately, you might actually accidentally extubate these patients, because if you extubate these patients, which is very depending on high PEEP, you might actually lose all the recruitment and there may be a problem re-intubating the patient. So you really hope not to be in that situation. So again, you need 5 people. At least I think it's 5 people, 2 at each side, and 1 is just dedicated to for the AT tube and the lines. And again, beside being aware that the lines might not disconnected, is that when you put the patient back, when you put the patient on a prone position, you need to make sure that they are padded really nice. You don't want ulcer. You don't want to pressure areas that is really not padded enough, and you might have an ulcer necrosis or stuff like that. That it's because, don't forget, which is we're going to talk about in the next slide, these patients, when you prone them, they're going to be in that position from 12 to 16 hours. 12 to 16 hours. That's a really long time that you need to make sure that they're padded appropriately. So what we end up doing in our center hospitals here is that we created a proning team. 2 team in the morning, 2 team in the evening, and 1 team at night for just an emergencies. So the morning team and the evening team actually go from ICU to an ICU, and basically the same team. They prone the patients. They already have their own checklist. Take them less than 5 minutes. Everybody know his role, and they just also every time they go to a place, they teach a new recruitment. But it's only this team who do that. So they prone in the morning and they basically put back spine in the evening, and that's how they continue to do it every day from an ICU to ICU, the same team. So that's what increase your proficiency. You decrease the chances of having a problem because you're not dealing with new people. You're not dealing with the of personnel that are not used to handle such a high alert, very sick, very, very, very sick patients. Okay, I hope I was able to explain that appropriately. Then the second question is, like, I've been talking here about what is proning and how long you do proning. Is like exactly why proning is important. So again, I'm putting here 12 to 16 hours because in the beginning, when they start doing the proning, they used to do it for 3 to 4 hours and actually did not find any improvement in mortality, and there is no actually much benefit. But for proning to actually work, it has to take this longer time. It has to be long enough for it to work. So 12 to 16 hours minimum, that to be able to see an effect. And mostly the effect is actually mortality benefits in the studies that done in proning. And there's many studies that we can reference to it, but I recommend you guys to read it as well. and they did a CAT scan for patients on supine, then prone, then supine, and you can see, because what the problem here, let's look at the first picture. So the first picture, you can see that the posterior portion of the lungs, they are completely collapsed, and there is, if you looked at it exactly, the VQ mismatch. These patients has really high shunt, high VQ mismatch, because of there's a mismatch in between the perfusion versus the oxygenation or the ventilation portion. And when you basically put them on prone position, you recruit more, you distribute the perfusion and the ventilation, you recruit more of the collapsed posterior alveoli. And the question is that, all right, okay, you're telling me that this CAT scan showing me that there is an actual improvement, but I need to understand two things. I need an actual number that tell me that this is actually working, and number two, I need another number that will tell me that I already burned all the chances for this proning to help. So that's what we do. We actually do a PF ratio, which is the PF to FI2 ratio, before you prone the patient. So in the acute respiratory distress syndrome, the Perlin, they basically classify the acute respiratory distress syndrome severity according to what is the ratio. So if you are between 200 and 300, you're mild. If you are between 100 and 200, you're a moderate. And if you are less than 100, you are severe ARDS. Okay, so these patients, when you put them, before you put them on from supine to prone position, you calculate their FiO2. I'm sorry, you calculate their PF ratio, P to F ratio. Then when you put them immediately prone, you calculate the P to F ratio, and you're really gonna see a really good improvement in their oxygenation. So you need to have a chart that you put it on the patient window or the door outside, anywhere you want to do it. And that's going to be your P to F ratio chart for proning. Okay. And every time you put a date there, every time you put the patient from a prone, from a supine to a proning position, you put before and after. Then when the next day you put before and after. When you start, like, let's say, for example, this patient, a P to F ratio before you proning them, it was like 110, really almost to become really severe, let's say even 100, which is severe ARDS. Then you prone the patient and you see this P to F ratio really improved to a 250. All right, that's really good jump and a good improvement. And day 1, day 2, day 3, now you day 4 and you did the proning, and the jump from 100 did not go all the way now to 250. It actually only went from 100 to 140. Next day it's 100 to 130. Now you're basically telling you the proning is not helpful anymore. You're basically burning this important carb. Now you start to have to think about, what should I do? Should I even continue to do proning, or should I now start talking to my colleagues in other centers to transfer this patient for an ECMO? Because you did everything now, and even if proning is not helping at all, and you're still in the severe acute respiratory distress syndrome, then that's a really, your patient is in a really bad situation. Okay. All right. So the last thing is the oxygenation problem. You should do ECMO. All right. So ECMO circuit. So the ECMO there is 2 types. I'm putting here one type. There is VV ECMO, which is veno-venous ECMO, and that's you do it if you have a respiratory failure. You just do what the lungs, you're replacing the work of the lung. Okay. Then there is a VA ECMO, veno-arterial ECMO. That's when you want to replace both the lungs and the heart problems. Usually patients with COVID-19, acute respiratory distress syndrome, they are one single system failure, although now we are seeing all these results that these patients have kidney problems, they have GI complications, they have hematological problems, that can be a different day for a different discussion. But for the time being, we're only going to talk about respiratory failure for these patients. And most of them, majority of them, if they need an ECMO, they will need a V ECMO. Don't let the color fool you here. So, okay. So you're saying like, Hassan, I'm seeing a red and a blue color. Does that mean the red is in the arterial and the blue is in the venous? Actually, even in a VV ECMO, you're still going to have the red and the blue, and it's not, and it's like what is from the body to the machine and what is the machine to the body. It's the same way as you do in a Doppler. What make the color red or blue is actually, is it this going away from the probe? Is this is going toward the probe? Even if you're doing a VV ECMO. So here, if you can see, they basically, it's a femoral. They are venous. Both veins are cannulated. So you can see here, and this is where the superior vena cava and the inferior vena cava at the right atrium, that's where you want your the arterial line, which is usually the blood that coming from the machine to the patient, because now you want some to go to the upper extremity and then something going down to the lower extremity. But other than veno-venous, you can use the right internal jugular vein, and that's what we have been doing here in the hospital. So for every patient we admit to the ICU, we tell the ICU team, please, if you are putting a central line in this patient, that's what we end up doing as a protocol. Any patient who got intubated, using the safety measures, and we admit them to the ICU, we immediately we line them up. By lining them up, we put an arterial line, a line in the right radial artery, but also at the same time we put a left neck, left IJ triple lumen center line. And the reason why is because we're trying to spare the right IJ for an ECMO if needed. So now all the nurses are aware, all the residents, all the fellows aware, a COVID patient, do not touch the right internal jugular, because if the patient got really sick and needed to be cannulated immediately, the main two veins that we are targeting is right IJ and right femoral, right internal jugular and right femoral vein. Those are the two lines that immediately we start accessing them and placing the sheets for the ECMO, because we have the ECMO team is in our hospital as well. So this is another tip. If you have, even if you don't have, or you want to transfer the patient, keep in mind that if you have the option, then do left triple lumen. If you want to do a dialysis catheter for your patients, a temporal dialysis catheter, that's a different story. You might end up trying to use the right IJ, because those are really long and a large catheter that it's easier to use it that way instead of going to the left IJ. But whatever easier to you, I just want to make sure that you guys understand this this trick, or not a trick. It's actually a point or an idea that keep in mind. That's some of the pearls that we learned in our hospital. All right, so this is a summary. This is the last slide I have for you guys before saying this is the Mass General hospital summary of every single thing we do in the ICU. Is our protocol that we follow. It's the ID team, the hematology team, the anesthesia team, the pulmonary team, the critical care team, all of them came together, and even including the cardiac surgery team, and they made this chart. So it's in every unit, okay? This chart does not mean that other hospitals are following what we're doing, and I will definitely share this with you guys as well. But keep in mind, this is what we are doing. So for example, let's look at the metal. What we're doing in our hospital, we are avoiding a high flow nasal cannula. So if you are in a Mass General hospital and you're already in the floor and you're requiring now 4 liters of oxygen, now you're requiring 6 liters of nasal cannula oxygenation. We do not go to high flow nasal cannula or non-invasive and ventilator like CPAP or PIPAP. We actually basically immediately intubate you and take you to the ICU. Do our hospitals do the same thing? No, because you need to think about what are your hospital facilities. If you don't have enough ventilations, if you intubate every patient who has on a 6-liter nasal cannula, you're not going to have a place to put these patients in. So it depends on what exactly that you have. But reasons why is when we talk to our respiratory therapists and our pulmonologists and everything, 2 things that we noticed is, number one, those patients, when you put them on number one, because this is and aerosolization. You don't want putting the patient on a high flow nasal cannula or CPAP. All that virus load is basically spread in the room. If you don't have a negative pressure room, that's also another problem. So you have this increased chances and exposing to the healthcare provider, including nurses, respiratory therapists, of that load, viral load that they just spread in the air. And we already know that these things can stay in the wall for many hours with the new studies. Number two is that if you let the patient take care of their own and what do you call it, pressure or like volume and on how much breath they can take, and you basically increase the chances of these patients can get tired and actually can cause a barotrauma for their own because they're trying to gasping for this high volumes. Because remember, you're controlling the tidal volume in these patients. So if once you put the patient on a mechanical ventilation and you set it up from 4 to 6 tidal volume, if the patient is on the floor and taking this large breath, they might actually be taking 8 to 9 ml per kilogram predicted body weight of very high volume. And if they continue to take this high volumes and you're not controlling that by putting them on a vent and sedating the patient, and you take care of that and control it, by the time you might intubate the patient, these patients might already been on a higher, their lungs are going to be more damaged than if you electively intubate them. So we just reviewed today exactly the mortality is like worldwide. There is around like 30 to 40%, I think 40% of mortality in the patients going to the ICU. Like in our hospital, it's only like 10 to 15%. And we're trying to figure out exactly why we have this low mortality, just to be able to see if we can share our experience with other hospitals. Maybe we can decrease the chances of intubating, of basically having a higher mortality. But we reported that to maybe we intubating these patients very, very, very early before they got really tired? Are we actually intubating too many patients that maybe did not need an intubation to begin with? And that's why we are able to put them off the vent. But also at the same time, if you looked at some of the patients we actually electively intubated at a 6-liter, some of them actually already on ECMO. It's indicate that you cannot tell who is actually going to be really, really, really sick to the point that they need an ECMO. We actually have one patient on a VA ECMO, not only on a VV that other 4 have. But you cannot tell. If you're going to say, like, I'm going to leave the patient on a 6-liter and I'm going to see who actually get better and get not, then I'll decide I should put this in nasal cannula on high flow and this patient on a CPAP. I think that you need to rethink about that. But also, again, you cannot intubate. This policy that we are doing might not be fit for other hospitals have only like 8 or 10 ICU beds, because if you're going to intubate every patient, you're going to be in really trouble. I'm just sharing our experience. I'm sharing this scheme of what we're actually doing for every single patient, not only including how we manage them on respiratory failure. We actually, what are the labs that we order on their admission, and what are the labs that we do every day, and when we should start, and even what are the protocols for antiviral and antibacterial in these patients. Again, all right, so this is thank you for everybody for attending this. Thanks for Dr. Abdullah and his team for asking me to join. This is my email address. This is my Twitter handle. This is my son, Ilyas. And I'm gonna leave it here for a minute so people can write that down and can be able to email me. And then in 1 minute, after I make sure that there's no questions that I need to go back to these slides, I will I'll take that down. All right, so I'm going back to the questions. Dr. Abdullah, you can tell me what you think, if you have any questions or anything. And while that time, I'm going to go through the questions and see if there's anything that I can be able to answer. All right.
Thank you very much, Mr. Hassan, and thank you for the attendees. A very impressive lecture, Dr. Hassan, although I've been almost 20 years plus from the ICU, the last time that I've done an ICU. I'm going to just, I've marked all the questions. I put them for you. They are marked so you can go over them. I think there are about 10 questions. If you could just go to the timeline of the questions in the chat, You can answer them one by one. I think just to share your alias and your link and whatever, you can just show it on the screen because I didn't see that. I have to turn the mic off here so that people can hear your answers without any interference. Thank you very much.
Okay. Thank you. So again, I'm going to leave this here for a minute. And then I'm going to go back to take a look at the okay, guys. And also, I'm planning to share the presentation as well with you guys, so you guys can benefit from it. And I'll also put, hopefully, once I get clean up the version, I'm gonna put in the last slide I'm gonna share with you guys in the actual platform is to have the same email address and the other information. All right. So, how come intubated patients will lower the risk of spreading the virus? Okay, so number one, I mean, if you look at these patients, it's the same question that we have in the operating room. We have this anesthesiologist or the other team saying like, "Hey, man, why do we really need to intubate these patients? Why not just basically put them if they needed an appendectomy or a hernia repair? Why not just do a spinal? Okay, just do a spinal, do a local anesthesia, and basically do the procedure." But if you looked at it, this patient is going to be coughing the entire time that the patient is going to be there, because don't forget, these are patients who have pneumonia from acute respiratory distress syndrome, mostly viral, that can be converted if they got a bacterial infection. So the patient is going to be coughing. The patient is going to be coughing. So while they are continually to cough, they're going to basically continue to spread the viral load. But if you intubate them, you basically have a seal and control of air going in and air going out, because the air when they exhale is going to go through a filter through the machine. So you basically control the amount of actual viral load. So that's the answer to your question, is exactly how you control by intubating them. This is how you actually control their viral load. Okay, I hope I'm able to answer that question. All right, so that's for Allah, who was asking the questions. The second question is like, thank you for this on time lecture. My question is, could we start prone stride forward from the beginning? So here's the thing. If you looked at the protocol that we have, we literally, what we end up doing is that we put you on Tidal volume of 8. We go down to 7. Then we do your first PEEP, and if we went up by 2, like for example, went from 6 to 8 to 10 PEEP, and you're not responsive, we brown you, even if it's that day 1 or day 2. Okay, so can we basically put them on prone immediately after? Well, yes, you can, but I want to see exactly, are they responsive to the PEEP, because most of these patients, when you put them on a mechanical ventilation and you give them time to rest, they actually show that their oxygenation requirements are not that high that you were expecting. So I would not prone every single one of them, but I will have a very, very, very short, low threshold to proning them. So that's what I do for our patients here. So we actually end up proning patients on day 1 and day 2 even of their admission to the ICU. Immediately, if we're noticing that with the, again, as I told you, with increasing in the PEEP is not helping at all. All right. Again, Ruqayya, if this answer did not answer you, please let me know, and I'll try again. It's all right. So Joseph, thank you very much. Very impressive. Thank you very much. Appreciate it. Could you please put the protocol back? Okay. All right. So just to let you know, Iyad, I will actually share the entire presentation once I talk with Dr. Abdullah. The protocol is going to be there. Every single thing that I talked about today is going to be there. Okay. So I'll make sure that you guys get the protocol. And even we have a more detailed protocol, almost 7 pages, that what we do here in the ICU. I'll be more than happy to share it with you guys, and you can email me if you need that. Okay, yeah. All right. So see, muscle relaxing, then oxygenation get worse. What is the explanation? Yeah, because sometimes the problem is that when you put them on a muscle relaxant, sometimes because their oxygenation is good, because the patient is still giving themselves like you're basically not controlling. Like you start by setting up their tidal volume of, for example, 450, and you're setting up the respiratory to this particular thing. But the still patient, they're not, because we did not paralyze them. They're actually not taking 400. They're taking 700. They're taking a uh, higher than you're actually setting them up. So that's why their oxygenation is bad, but it's not terrible. Then you all of a sudden you put them on a muscle relaxant or you paralyze them, they drop. So you immediately have to make sure it's mostly that now you don't have that kind of extra help that you had it from the patient. You're basically purely depending on the machine, and these patients have problems. As I told you, it's a pulmonary edema picture like they need a higher P. Now you basically, the patient is not able to take anything. Now you have more alveoli that become atelectatic on a lung that has very low compliance and full of fluids from the ARDS. So you're expecting that to have a little bit of worsening in their oxygenation in the beginning, but this should not continue. It just basically now you need to make sure that you adjust the setting accordingly according to the protocol that I guys showed you, which is, I remember I told you, if you have an oxygenation problem, follow then move on to the next one. I told you if you can move up to the mode, you can prone. After you make sure you basically utilize the higher scale in the ARDS net protocol, the P to FI2 ratio that I talked about. Okay, all right. So thank you guys. So could you please put the protocol back? I answered. All right, for COVID-19 patients, acidosis, oral calosis, blood gas is better to decrease virus replication rate in blood. I'm not sure, to tell you the truth. We're actually looking into. There's so many papers going right now. It's fascinating to me, to tell you the truth, and the how much the collaboration that the world came to in trying to fight such a pandemic. The amount of papers are generated on every single day. It's just fascinating. The even our protocol that I showed you guys now, this is the third or the fourth version. We learned from the Italian, we learned from the Seattle experience, we learned from the China experience, and what is going on right now. And we actually continue to adjust and fix and modify our protocol to the latest result. For example, one important thing is that should you anticoagulate patients with a D dimer about 3,000? We went up and down in these patients about should we or should we not. We started with anticoagulating these patients, but those patients who have rectal tube, they start bleeding from those rectal tube ulcers. Although if they are on anticoagulation, should we have rectal tube or not? But these patients, when you put them on prone position, most of the time you need them to have a rectal tube to be able. But if you did not anticoagulate them, you start noticing that these patients have clotting their central line. Clotting mostly their dialysis catheter, they clotting their ECMO lines. So it's a very interesting that how fast we are changing. And to tell you the truth, I cannot answer your question. I can look it up and let you know, but I won't be surprised that tomorrow we'll have a different opinion about what we're even talking about right now. But I tried to bring the latest that we have and what is going on right now. But I promise you that if we talked about this topic in 1 month from now, I'm gonna recommend you small things different. But eventually, it's an ARDS. This is what I told you, how to deal with an ARDS patient. These are the main things that you can take a look at. And if you expand in what I taught you, I'm sure that you guys are going to be able to at least manage events in these patients. You still need to read about the ABG and how to interpret that, and adjustment in the vent setting, what will do to your ABG. So got some other things. All right. Biothreat fluids. Okay. Can you please explain more about when a patient is not responding to PEEP? When the patient is not responding to PEEP. Okay. I'm not sure whether I understand it right. So when we say that the patient is not responding to PEEP, if you increase the PEEP and you waited and you watched the patient oxygenation and you took an ABG, you're expecting that that higher PEEP, after a while, after you recruit more alveolus, you're going to have improvement in the oxygenation. So let's say, for example, you're on a PEEP of 8, you're 80 of FI2, and you take a look at their patient partial oxygenation, and it's 59, which is really low. You increase the PEEP already now from 6 to already, or let's say you're 12 now, and it's still 56, or even maybe let's say 55, although you're already FI2 for 100%. So now you're in a FI2 for 100%. You increase your PEEP from 6 to 8 to 10 to 12, and you actually got worsened in your oxygenation, especially when we're talking about your partial oxygenation, your ABG, and then that's what I mean by this is a PEEP not responsive. So these are patients that you should think about pruning them. Actually, this is for a question for Lujane Khalid. Let me know if I was able to answer that question, or that's what you meant by your question. Right. So for recruitment maneuver, this is a question by Dr. Asier. There is many ways. The two concepts or words that I did not list that you guys should you're gonna be hearing about is called a best PEEP. Like what is the best PEEP for this patient is, and the second concept is recruitment maneuver, like how you recruit more alveoli. So for best PEEP, which is I can try to bring it up, is basically this is you're gonna ask your nurse or respiratory therapist to sit down with the mechanical ventilation beside the patient for almost half an hour to an hour. And what she ended up doing is she ended up increasing the PEEP by 2. Then she basically measured the compliance. And compliance, you can measure that. Is basically what I say by compliance is, let's say, for example, you have a rubber. Let's say you have a rubber, like circular rubber. If it's really tight, you're going to have a lot of volume to slightly change. So compliance, it's a change on volume on the change of pressure. It's inversely. So if you increase higher volume to very, very slow change in the compliance, then that's and very low change in the pressure. That's mean this is really, really compliance lung. That's mean like the COPD patient. You require this much of increase in the entire volume, and immediately all of a sudden you have this no change in the pressure, because that's the numerator over denominator. But if you require a lot of volume, and there is like the amount of volume that increases, like the change in the pressure is it's completely not correlating. And like, so for example, to inflate a very hard, thick lung, you really require a lot of pressure to be able to open that lung. And unfortunately, that's what is the picture in the patients with a respiratory distress syndrome. When we actually did an autopsy, they found a very thick mucus lungs with alveolar wall destruction, similar to what actually other ARDS is. But that's what the meaning is, that you need to figure out exactly what is the best PEEP. And the meaning of best PEEP is they actually put a chart, and they basically calculate with every PEEP what is the compliance is. And then they do a static. I'm not going to talk more in detail. There's a statics and there's dynamic way of measuring the compliance, and then you plot. Okay. And if I don't, let me just okay. All right, so you're gonna end up having something like that. So you're gonna end up measuring the compliance, which is gonna be like this, and that's how you basically the amount of change on volume to the amount of change of pressure, and all of a sudden the lungs popped open and immediately start having this kind of line. So let me just do this. All right, so you're gonna have this slowly line like that. Then all of a sudden you're gonna have this really improvement in the actual compliance, and then now the lung has become over stretching. Okay, so this is exactly This is exactly the sweet zone where you want your compliance is. So you're gonna take a look exactly what is the PEEP here, what is the PEEP that achieved this here, and you're exactly gonna be the lowest PEEP that you end up needing to achieve this perfect zone. And that's how we basically actually can I have to draw it more details for you guys. You can see more important, but um, I don't want to dig into details. But that's what is the best P for this patient, which is different from one patient to another. Some people they crack the PEEP all the way up to 20 and then 22 and then they go down. It's called decremental PEEP, which is basically you go down on the PEEP. And the problem with that, they notice that these patients will develop higher pneumothoraxes, higher paratrauma, because that's what they used to say, like, oh yeah, just crack the PEEP to 22, then slightly go down. But these are patients who have a very, very, very frail lung, although they're thick wall. You do not want to destroy, you don't want to cause these patients to have a pneumothorax. So we recommend do not do decremental PEEP, which is going up to 22, 24, then go down. We ask them, I recommend you guys to do incremental PEEP. Start down and go up. That will decrease your chances of having a birth trauma. Dr. Abdullah, you can intervene anytime, and if we are going beyond, we're almost reaching at 2 hours. But if I'm going beyond that what it's supposed to be, you can always intervene. Until then, I'm gonna go through the questions and try to make sure that I answer. Is early pruning show any mortality benefit? If yes, pruning overall actually showed a mortality benefit, and I'm not sure whether you mean by early pruning. If you need a pruning, and I told you when you will actually need a pruning, no improvement or PEEP not responsive. In acute respiratory distress syndrome, pruning actually and lung protective ventilator 4 to 6 is actually one of the two things that I think almost those are the most important that showed an actually mortality benefit. Then the question is that nitric oxide, is the nitric oxide can show there is improvement. It's shown improvement in the oxygenation, but actually showed no mortality benefit. But low tidal volume and pruning, those are the two that showed mortality benefit. Okay, correct. Sometimes when patients receive, when and why decide to probe patient, I think prone, which is I already said. Okay, how can I know if the patient PEEP responsive or not? I hope I actually was able to explain that. Regarding Plateau, what about sedation? What about sedation? I'm not sure, Mohammed, who answered this question. What do you mean by? I think the patient, when the patient is, we actually usually sedate the patient to do the plateau pressure. It's or even when we're gonna do the recruitment or the getting the best PEEP, the patient when the patients are sedated are really the best time you can actually sedate and fully control the event. Then this is the best time for you to do the recruitment. So Anas, what about PEEP 5 of PEEP and FI2 of 100%? Yeah, this is actually what I start. I started a PEEP of 5, and then I go in FI2 for 100%. Then I start going down on the FI2 first. I'm not sure whether that's what you mean or not. But if you don't mean, if you're saying that I actually started at a PEEP of 5 and an FI2 of 35%, and I actually went all the way up on an FI2 to 100% while maintaining the PEEP of 5, you need to follow up the high PEEP, low FI2, and we are talking about ARDS patient. You need to follow that kind of scale, and instead of just going up all the way to 100% FI2 without increasing the PEEP. So I'd recommend you when you put a patient on a mechanical ventilation, sedate them, follow, get the best PEEP that these patients like, calculate and write down on a piece of paper on the patient front, like what is the 4 ml per kilogram predicted body weight is, and what is 6, what is 8, and just have him there so the nurses and the respiratory therapist able to be immediately, when it's like you can say like, hey, put the patient on 4. They don't need to. They immediately can take a look at the paper that you wrote down in front, and they will know what is 4 to this particular patient. Okay, is it real that that COVID is patient's ARDS or mimic ARDS. Sorry about that. So it is ARDS. The question is it a different type of ARDS or not? But overall, don't waste your time on trying to figure out exactly if this is a patient is an ARDS or not, and should I treat them differently? Because I do believe this is a lot of people wasting time trying to understand is this a typical ARDS or not, and they try to deviate from the actual appropriate care of a patient with an ARDS. So far, what is shown that is proved, and that is just treat the patient as an ARDS. Understand and appreciate the differences, but do not deviate from the protocols that's shown to improve the patient mortality. And what you're doing, you're just basically buying time for the patient for them to recover. You put them in mechanical ventilation, you make sure they're oxygenation, and you just watch them. Most of the times we round on the patient for 24 hours with minimal changes other than just tweaking up the PEEP a little bit, and then that's it. Then the second question, which is I hope I can be able to talk about, is that you have a patient, really awesome. You are already 5-on-5 pressure support, and you're already FiO2 of 35%. They're a little bit of sedation. They're awake. They're following command, and they want their tube to come out. Okay. Usually in a patient with an obese patient, sometimes we actually extubate them on a PEEP of 7, PEEP of 8, taking into account that the chest wall. I'm talking about non-ARDS patients here. Okay. What about ARDS patients? Because acceptable percentage of re-intubation rate in an ICU, it's a 10 to 12%, around that time. If you have less than that number, that's mean you're not intubating the patients quick enough. If you have higher than that's number, that's basically you're a cowboy. You're extubating patients that they're not ready yet. So you need to recalculate. And every ICU should have that number, how many re-intubation rate you have in your unit. In these particular patients, acute respiratory distress syndrome with the COVID-19, you actually should accept a little bit higher re-intubation rate. You can be all the way to 15 to 20%, because these patients are not typical. They're not the typical extubated patients because the problem with these patients, they're really high PEEP dependent. So you go down to a PEEP of 5, you basically you just you say, okay, ABG look great. I'm gonna do spontaneous breathing trial, and you extubate the patient. 2 hours after, they become really sick. Not all of them, but a good number of them. They start noticing they become really, really tired, hypoxic, short of breath, and you re-intubate these patients. So they're trying to figure out exactly what can we do to decrease the chances. So one of the ways you can decrease the chances is that what we recommend is that when you reach 5 of 5, and you're the very low FiO2 of 35%, we advise the patients, the people, we advise you guys is just shut down the PEEP, go down to zero PEEP. Keep the tube in, go down to zero PEEP. You can put a little bit of pressure support, but you can do completely 0 of 0, or at least zero PEEP, and watch the patient for 2 hours. Because basically now you're not providing them the PEEP, and they usually fail within the 2 hours. If your patients survive the 2 hours of zero PEEP, the chances are less for them that need it intubated, but it's not zero. Okay, they might get sick at 6 hours, 12 hours after, but that's also another pearl that you need to know. Other than that, also, again, these are pulmonary edema patients. You need to have a fluid conservative. You need to be really decrease the amount of IV fluids that you're giving these patients. Diurese them. Make sure that they're in the negative side, because if you made them a lot of positive fluids, these patients are going to be really hard to get them out of the mechanical ventilation or even improve their oxygenation. So in the protocol that I show you guys, it's written conservative fluid resuscitation, and keep your patients on the dry side. Okay, what is the most indications for extubations? What is the most indications for extubations? I mean, the same patient is the same as any other patients. You extubate them when they're ready to be extubated. The only difference is, as I told you, is that we have a low threshold about this patient getting re-intubated, and do an extra step. Keep them, make sure that before you extubate them, they're really dry. Do a 2 hours trial of zero PEEP. when you extubate them, then the second question, you're anticipating that these patients, which is the study said that most of these patients, when they're about to get extubated, for the treatment that they have, the viral load is low. So you can do a trials of FiO2, trials of high flow nasal cannula. So when you extubate these patients, you can put them in high flow nasal cannula, make sure all the, all the nursing staff and all the people are, wearing the protective gears and everything every time they enter the room, and even if possible on a negative pressure room. But hopefully, because the high flow give you a 5 a peep, that makes you actually be a little bit helpful for these patients. So that's another method, another pearl that you can keep in your sleeve. Okay. All right. So yes, Doctor, I have. Oh, thank you, Eugene. I think it is not really typical ARDS. Yeah, it is. Here's the thing: it's not a typical ARDS, but the problem that I don't want people to get confused is that, oh yeah, he's talking to us about, Hassan is telling us about acute respiratory distress syndrome and all of that thing. Whatever he's telling us is not going to be implemented in I'll have to change that. And like all our patients we're taking care of, we have currently 162 ICU patients who are admitted and intubated actually in the ICU with a COVID positive patient. So we already opened 5 new ICUs just to accommodate, and we're literally following the things that I'm telling you right now. And it's every patient has their own policy, but please look into evidence base, look into other people's experience. I'll be more than happy to share our protocol. Please explore other places and read their protocols and just use your common sense and what is proven. And so far with this new beast, what we have proven so far that it worked is actually following the ARDS net and and just a few advices that we have few advices that we learned in our experience now since the whole thing started. Okay, what else? Thank you very much, guys. How can intubated patients would lower the risk of spreading the virus? Okay. So again, if I think I answered this question. Yeah, when you intubate the patients, you basically control whatever the amount of the viral load is going to come through the patient. They're not going to cough anymore. All the air is going to come out through your ET tube that is going to go through a filter. So when you suction, and especially we're doing that in the patients who have you already inflating their balloon. Okay, so if when you deflate the balloon for one reason or another, the air, the patient can cough and exhales and virus load can go around the ET tube. So we're talking about a patient who had balloon is inflated. Every air is coming out solely and only from the ET tube through a filter. So that's why when I said, how come that lowered the spread in an intubated patient? This is how. Okay. Is it really okay? I think. Let me just go make sure. Okay, so Dr. Abdullah, I think from my side, I said what I need to say. I don't see any new questions, but I'll be more than happy to answer anything more. And if you want to add anything to say, then.
Thank you very much, Dr. Hassan. It was really very nice and informative presentation on our first webinar. Thank you so much. I hope the attendees today have learned what they need to learn to care for their COVID-19 patients in those critical areas. Thank you very much, and thanks to my colleagues who have actually spared no efforts to make this presentation happen. I know it's on a Friday here in Saudi, and I know it's still like a weekend also in North America and some parts of the world. Thank you very much, Dr. Hassan. I want to just highlight that the presentation will be available for 72 hours after the session today, so people can refer to it and they can actually look at your interactions and discussions for the questions. And again, I put the URL of our website, which is not conventional. It's basically utilizes the social media tools to connect with people. And because this is one of the things about learning, is that people really, they get disconnected from the learning process. So we're actually behind connecting the dots and make people really to continue hone their lifelong learning skills. Thank you very much, and I hope we see you in another webinar, Dr. Hassan, inshallah.
No
And
problem.
stay safe in your work. God bless you. يحفظكم الله جميعا. Thank you very much.
Thank you very much for everybody. Things like Abdullah and your team for your delegate work. And I'll be more than happy to present frequent questions, whether it's trauma, emergency surgery, or critical care in the future.